Yeah, this is the one.
Patient in dorsal lithotomy, place Foley catheter for recognition of the urethrovesical junction. Use 2 Alice clamps to grasp the vaginal epithelium at the urethrovesical junction and at the vaginal apex. Inject hydrodissection solution subepithelially. I use 20 units of Putrescin, 20 cc's plain 0.5% Marcaine in 100 cc's of normal saline mixture. I typically use 20 cc's of mixture for the hydrodissection. With a scalpel, incise the vaginal epithelium between the 2 Alice clamps, from the urethrovesical junction to the apex. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Surgical tips. Place an Alice clamp on the epithelial edge. Using your forefinger as traction, use Metzenbaum scissors to carefully dissect the fibromuscular layer away. An assistant can maintain traction medially on the underlying muscularis tissue layer with atraumatic pickups. Providing traction and countertraction is very important for a clean dissection. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Delayed absorbable suture. Plicate the prolapsed fibromuscular layer in 1 or 2 mattress layers. Surgical tips. Avoid tension and avoid taking excessively deep bites to prevent injury to the underlying trigone and ureteric orifices. If the prolapse is particularly large, consider placing an initial purse string suture. Trim excess vaginal epithelium and re-approximate the vaginal epithelium with 2O or 3O delayed absorbable suture in interrupted, subcuticular, or running fashion. Perform cystoscopy for evaluation of bladder integrity and ureteral patency.
Thank you. We can go back to presentation. All right, so venous plexus bleeding, although she injected quite a generous amount of pitressin, which is vasoconstrictor, If it is not available, we can also use adrenaline solution along with bupivacaine. So benefit of bupivacaine will be because we do it as or daycare surgery, so it's not painful for the patient. So I use 0.5% bupivacaine with 1 in 200,000 adrenaline in a total of 20 to 30 mils. And sometimes venous plexus bleeding can happen. Most of the time, if it is a daycare surgery, we have to sort that out. We cannot use diathermy too much, so we use 2-vicryl to put stitches rather than using too much diathermy on anterior vaginal wall. Cystoscopy is not a routine. In my cases, when I do anterior repair, but if I have done very extensive dissection, then I do cystoscopy, but it's not a routine procedure. So if you use a lot of diathermy, there is risk of development of fistula. So we need to try to avoid diathermy in vagina. And again, stress incontinence might be unmasked with correction of urethral kinking associated with vaginal wall prolapse. Okay, so success rate initially when they say 100%, recurrence rate of 40%, 43% was reported. So anterior repair is the one with the highest failure rate in all of the prolapse surgery. And this was the area of my research. So my research paper, what are the reasons why anterior repair fails? So it was a biomechanical study. So we took pieces of the trimmings from anterior vaginal wall from various patients when we did repair surgery, and we analyzed these in the lab to see biomechanical properties of the tissues and amount of collagen, to see later on which patients developed recurrence. And then we compared, so it was period of 3 years, and then we compared what was the collagen quality, quantity of collagen, and bioelastic characteristics, and whether there was any correlation with recurrence. So good news was that there was no correlation. So we cannot blame collagen, that it was collagen or biomechanical elasticity problem. That's why people have recurrence. So this means it is surgical technique. And top of the list is if we do not correct the apical support, anterior prolapse will always fail. Okay, we'll talk about that. Let's go forward. Posterior compartment. So it's exactly same type of technique. The reason it is a busy slide, it's for trainees because you are going to get a soft copy. So these are the surgical steps, but all the experienced people, obviously they do this routinely. The main thing is whenever you do posterior repair, my tip will be do not excise any excess skin. Anterior repair, you can get rid of excess skin, but in posterior vaginal wall, no matter how much loose skin is there, do not trim it, because that is the leading cause of dyspareunia, because then it causes stretching and scarring. So do not trim it, no matter how loose it looks. If you have approximated the fascia underneath, the loose skin will get caught and it will get better with passage of time. So do not trim the skin. And sometimes genital hiatus correction is really important. If genital hiatus is more than 4 centimeters, a tight perineorrhaphy is really important to give support at the end of the posterior repair. So again, bleeding and small bowel injury, fistula, infection, recurrence, these are the risk factors. But the top of the list is dyspareunia, which is usually the result of a tight repair with excessive vaginal narrowing. Women can try lubrication and vaginal dilators, but may eventually need Fenton's repair to correct the narrowing at the introitus. So recurrence rate is 13% to 22%, and bowel dysfunction. So sometimes the obstructive defecation does not get better after posterior repair, because as we were discussing yesterday, people sometimes need splinting or digitation to empty their bowel. And when we tell them we are going to do posterior repair, they hope that after posterior repair they will be able to open their bowel easily. It does not happen in every case, because sometimes the etiology of that is rectorectal intussusception and not the rectocele. So if you have done a good rectocele repair, and when you see her for follow-up, the prolapse has completely gone, but the symptoms have not gone, then you will request MRI defecography, and which will diagnose rectorectal intussusception. If you talk to radiologists, it's very easy to do. All they have to do, put some contrast in the rectum, make the patient sit in a commode and do MRI when she is passing it. So it will diagnose intussusception, which can be corrected by colorectal colleagues. So now the next video is about posterior repair. I don't think there is any need to see that. It is similar to what we saw. Unless somebody would like to see posterior repair, I think it will take long time. We'll move on to interesting stuff later on. Okay, so now we are talking about vaginal hysterectomy. Obviously, this is one of the favorite operations what urogynecologists do. Um, but if there is apical weakness, vaginal hysterectomy does not solve the problem. So after vaginal hysterectomy, as Dr. Seema was mentioning yesterday, we must do McCall's scaldoplasty, and there are various techniques which can be done like uterosacral ligament plication, McCall's scaldoplasty, and the technique which I have learned from my teachers, the one I do is a bit different. So I'll talk about that in a minute. It is similar, but it is a bit different. Gives us good result. Again, these steps are for trainees.
In rectocele repair also you do something like
Anchorage suture.
Yeah.
Shall I mention that?
Because on the
Yeah.
LOA position you said is more common. So
Yeah.
left side fascia is more torn and
Yeah,
goes
yeah.
higher up.
Yeah, yeah.
And you search that and plicate it.
Okay, so let's mention that. That is called, the name of that technique, I have forgotten. It's an Indian consultant in Southampton, and he started that. So he said it should be named after him. He's a nice chap. So, but we just call it anchorage suture. So what we do, once we have done a good dissection and all the fascia is in front of us, let me make a little picture there. So it will be easier.
That step is important.
Oh, I'm impressed you remembered that, Dr. Sima. Okay, so this is our patient. This is urethra, and this is where we are operating. And this is anus, and as you can see. So we have opened up here, yeah. So we have done a lot of dissection. So we have got a fascia now. This is all dissected fascia, like that. And this is the upper margin of the posterior wall. So just think about anterior wall, there is no prolapse, and we can see cervix is there, okay? So we have dissected up till cervix, right in the pouch of Douglas, we have gone there. And what we realized, that one-sided fascia, there is a break there, so there is no attachment. This side is attached there, but there is a break of this fascia. So unless we correct that part, nothing will happen, no matter how good plication we do. So the first stitch after dissection, what we do, we take to a vital, we take a bite from here, we take one single bite from there, we tie 2 knots, not 3, in the midline, so this becomes joined like that, and then we take the needle out here in the vagina. We get the needle out here, we take another bite, and we come in the vagina. So what happens? This broken fascia gets attached to the top of the vagina, close to the cervix. So this is the first anchorage suture. Then I'll take one suture here, one here, get out there, one anchorage suture here, one anchorage suture here, one here. So the break of fascia just underneath the cervix, I will lift it up with 3 anchorage suture. I'll come out in the vagina, go back into the vagina and tie 3 knots. So 1 knot there, one there, one there. So this means the break here, which was the reason when the baby says pass through or something, that area, the area there was nothing, I have filled that. So that also does a good job for prevention of future entrocele. Yeah, because you think about it, we are right in the posterior fornix. So these 3 anchorage suture, they help prevent. And once I have done that, then I do a normal plication. Just a normal plication, like that. But at the end, you must, when I do posterior repair, Dr. Seema might remember, I never start with a vertical incision. I always start with a diamond shaped incision from the perineum. No matter whether they need perineorectomy or not, I always start the section. I just make a tiny slither of skin away. I make a rectangle. I remove this triangle, remove this skin. Then I do infiltration and then I start dissecting upward. And when I start suturing, I put these 3 anchorage suture and then I start the plication. So that is just a little tip which you remember. But usually good results. Okay, so now let's go back. Sorry about this busy slide, but I'm sure there is a use for it. Okay, let's go to the next slide. So we are talking about complication. As we know, bleeding can happen, bladder bowel injury. voiding dysfunction, recurrence of prolapse, dyspareunia, conversion to laparotomy. We are talking about vaginal hysterectomy here. Has anyone had any huge hematomas after vaginal hysterectomy or after repair? No?
Long back when I was a PG, I witnessed one case where both the side uterine vessels they slipped, and she was a very old lady,
Hmm.
and she had bilateral broad ligament
Yeah.
hematoma because we used to go for post-operative round in
Hmm.
the evening, the day our consultant used to operate. So when I saw that patient, she was absolutely pale and in shock. And
Hmm.
I had to call that time, lot of phone calls and all, they were not there. So she was attending some function. I ran, I called her there, and then she was operated. So that was only the
Hmm.
one case where I saw
Hmm.
bilateral broad ligament hematoma due to slippage of
Yeah, last year I saw one. It was a retroperitoneal hematoma after vaginal hysterectomy. And the patient's HB dropped by 6 points and she was in shock. But on examination, vaginal examination, there is no hematoma. Pelvic examination, there is no hematoma. Because when it is retroperitoneal, you can't pick it up. So you have to have an MRI scan which confirmed 20 centimeter retroperitoneal hematoma. But most of the time, retroperitoneal hematomas are managed conservatively. You never open them up. So you just give her blood, give tranexamic acid, give antibiotics to prevent infection, and she was perfectly fine in 3 days' time and she went home. So no surgery needed. Okay, so these are the vault hematoma after vaginal hysterectomy is fairly common. If you sorry? Conservative, always conservative, retroperitoneal hematoma. So conservative means you keep checking her hemoglobin every 12 hours, give her 2 units of bloods, keep checking vital signs, give antibiotics, and give tranexamic acid. So mostly retroperitoneal are never open because where are you going to open is tricky. But before that, in order to manage them conservatively, you have an MRI scan before that. That is vital. And it is with contrast to see if there is a spurting vessel or not. So if there is a spurting vessel which is continuous bleeding, then you go and manage it with embolization. Still you don't open them. You do embolization from groin, and then if there is no spurting vessel, you just manage them conservatively.
is the reason like if infundibulopelvic ligament from there if the hematoma is forming that goes retroperitoneal and up and it is mostly not recognizable from the
Exactly,
bleeding itself.
exactly. Okay, so uterine preservation procedures, as Dr. Seema was mentioning, without hysterectomy we have to manage. So it is fertility preserving surgery, and it also reduces morbidity when we are not removing uterus. Okay, so dissection needing for hysterectomy may cause pelvic neuropathy and disrupt natural supporting attachment to uterosacral ligaments, leading to increased risk of urinary incontinence, prolapse, and sexual dysfunction. So we should never take hysterectomy lightly, and we should try to avoid hysterectomy because uterus does have some function in various ways in bowel and bladder and sexual function. So sacrospinous hysteropexy. So we have a device here, somewhere here. Dr. Shazi, can you pass me through this Capio device? That's the one which is open, the opened one.
डॉक्टर निशा अच्छा वो दिया
Oh, I got it actually.
ओके
I remember. So the device which is shown here, I brought one with me. So that's what it is. That's all it is. This is called Capio device. Yeah. So it is Boston Scientific which makes it. So it is self-anchoring device because when you do sacrospinous ligament fixation with Meyer hook or dissection, it's a lot of dissection and it is risky because of neurovascular bundle there, and it is a lot of hard work for the surgeon. With this it is so quick. So what you do, all you need to do, you feel where ischial spines are. Yeah, if very obese patient and you can't feel spine, then you are in trouble. But you need to try to feel the ischial spines, and then you start going your dissection on the posterior vaginal wall. You try to go, but actual extent of the hole is only that big, because you don't need to see it. You just need to feel it, and with your fingertip, you do the dissection. You keep going, you keep cleaning, you keep try to reach the spine. Once you have reached the spine, then your left hand finger, index finger, goes there in the spine, and with the right hand, there is a special suture there, which is not a needle, it is like a small bullet. So it is like 2-3 millimeter only. So which is capio polypropylene suture. So you can barely see it. I'm sure you can't see, even I can't see. So it's such a small bullet. So what you do, you mount it like that. And now I have mounted it. And the way you check whether you have mounted it well, it should not be pinching on your needle. So it's not pricking me. This means it should go completely in. And there's this thread. This goes in a groove there. So there are 2-3 grooves, one there, one there, one there, and one there. So now you think about it, it's like an arrow, isn't it? So now you are holding it like that with one hand, and this hand is going there where the spine is. For example, ligament is just there. So my finger is on the ligament, and then I go in there because it only needs a small space. This is Capio Slim. Original version is a bit thicker. So I go to the ligament with my finger, I guide my capio, that yes, this is the ligament, and then I fire it like that. So what it does, the needle will go through the ligament and the device will bring it back. So it will loop it. And then I take one more. So I take 2 stitches on each side. You can do unilateral, but I usually do bilateral. So I do dissection right side as well as left side. So I put 2 stitches on each side. My theory is that the vagina remains symmetrical. So it is aligned in the midline and it is easy, and then I don't have to put too much tension on 2 stitches because I have 2 on each side. So likelihood of success is higher. So similarly, this I am telling you for vault prolapse. But if there is cervix, when I take the stitch on the sacrospinous ligament, then on the other end of the stitch, there can be a needle, or you take free Mayo needle, you put it in the needle and you take a bite on the back of the cervix. And then you tie it inside vagina because this is not a dissolvable stitch. And then Dr. Seema yesterday beautifully explained how you close it on top of it. So it can be done with the uterus in, which is sacrohysteropexy, or sacrospinous hysteropexy, or you do it for vault prolapse, which is sacrospinous ligament fixation. So hematoma is a complication, bowel injury, right buttock pain. So you must write that on the consent form, right buttock pain, because if it happens, it's quite a bad pain. Luckily, it doesn't happen very common. Just 5% of patient may develop it, and it should get better within 3 months. Small proportion of women, it never gets better, and you have to remove the stitch. I've never removed it, but you need to know theoretically. So when you do sacrospinous ligament fixation, later on people can develop anterior prolapse because now all the traction has gone to the posterior, so anterior prolapse can develop. Similarly, when people have Birch colposuspension, later on they can develop posterior vaginal prolapse. So whenever we disturb one compartment, other compartment can be compromised, and you must counsel patient that this is not the end of the story. So what this slide is discussing, if you avoid hysterectomy, you save a lot of blood and morbidity, quicker recovery, less pain, and RCT is mentioned for trainees to make a note when you have a soft copy of this. Manchester repair. I'm sure you all do this. Yeah, this is one of the beautiful operations which has low morbidity, and I really like it. And I'm sure a lot of people, even trainees, would have seen this. It is done. You have to choose your patient well. It cannot be done when all the uterus is lying in the vagina and you try to do Manchester repair. It is only isolated, elongated cervix. Okay, sometime for some strange reason, cervix does grow in some people. So uterus normally present where it should be present, it is elongated cervix. And the test is you can see the whole cervix outside when you do the speculum. It should not be a globular appearance which you see with the uterine prolapse. So you have identified isolated elongation of the cervix, then it's a good procedure. There is a video there, but I'm sure you all can make a note of this link when you have soft copy and look at this video on YouTube yourself. Sacrohysteropaxy. So again, when we are trying to save the uterus, so we can wrap around the mesh. What mesh do you have in India? What type of mesh you have?
Proline.
Polypropylene, the blue color,
Yeah.
and Y-shaped mesh.
We make it Y shape.
Okay,
It comes in triangular and we make it
okay, okay,
Y shape, and according to the distance that we adjust it,
okay.
cut the space.
So we in the UK we have stopped using polypropylene meshes. We have started using Dynamesh. So it is half the weight of polypropylene mesh, and it comes in the form of Y. So if there are any expired one, I'll bring some next time. So it's quite nice, less risk of erosion or exposure. So abdominal sacrohysteropaxy, we wrap the mesh around cervix, we attach the mesh to cervix, we go through broad ligament, and then we attach the mesh to the anterior longitudinal ligament on front of the sacrum.
Actually, attaching this Y, people have different opinion where to attach this Y.
Exactly. Hmm.
So some people, like what we do it, one side we attach to the uterosacral ligament, the other side we bring medial to uterine. We don't disturb the uterine vessel.
Hmm.
We bring medial to uterine, we pass it through the broad ligament, bring it anteriorly and attach to this
Front of the
area.
cervix, yeah.
So with this, there is very nice pull onto the uterus, and it is well version, yeah.
Yeah.
Uterus is nicely anti-verted, anti-flexed, and the other part, of course, to the anterior ligament of the sacrum at the level of S5, S4, S5, at brim,
Okay.
sacral
So do
bottom.
you recommend cesarean?
Yeah,
Okay.
yeah,
So you counsel them very well that
yeah.
they must never try to have a.
Our patient conceived, she had delivered one,
Okay.
and again she is pregnant.
Okay.
Yeah.
That's good. Laparoscopic approach is easier in a way that the view is beautiful on laparoscopic approach. So it's easier to dissect the sacral part because of the gas, all the bowel is away and we can see beautifully. And sometimes you can use tacks to attach the mesh with the little screws to the sacrum, but the better is to use Ethibond. So there is a video again. If somebody wants to see, I can click it. Otherwise, later on you can see in the link. Otherwise, we'll be here all evening. So post-hysterectomy vaginal vault prolapse surgery. Uh,
Tell us that also. How do you suspend the vault after vaginal
yeah,
hysterectomy?
so that's what I was
Because
trying
that
to.
was also your.
My technique is a bit. This I learned from my teacher in Plymouth. So let's have a look. So that's quite a unique. I don't know whether you saw me doing that vaginal hysterectomy because 100% I've used the same technique. So it's quite interesting and it's very easy. So what happens? So how to draw that now? Yes, so this is our pedicle for cardinal ligament. We have already, cervix is somewhere here, yeah? And this is our pedicle for uterosacral ligament. So we have separated cervix from uterosacral first and then cardinal, yeah? So uterus is here. So normally people cut the suture. So I don't cut the suture. So whenever I take uterosacral ligament, I keep my two sutures attached like that. So I apply a clip there. So clip is attached there. So now I have one attached there with a clip. So suture where I tied the uterosacral ligament, I just cut the needle and rest of the thread, which is quite long, at least 7-8 inches long, I attach to a clip and I let it hang. And then I go to cardinal ligament. So I do exactly same, and these two I put a clip on the side here. These long stitches, I attach them to the side. For now, so I can manage them after hysterectomy, whatever I want to do with them. So after that, I take the usual steps and I get rid of the uterus. Now uterus is gone now. So when uterus is gone, that is the point when people do McCall's scaldoplasty. Yeah. So instead I don't do that ever. So now I just close the peritoneum. So I have checked everything. There is no bleeding, and I have just taken a purse